Well, good afternoon, and I really have the pleasure of bringing the greetings from my bureau, this called the Central Bureau of Health Intelligence in the Ministry of Health and Family Welfare. And this is the national nodal institution for the entire health intelligence in the country. And we have got a website which I hope if you go through, you can understand our functioning. We are spread over the entire country in the different regions. And my website is www.cbhidghs.nic.in. Well, I'm really thankful to eHealth, Dipanjan, and the entire group for giving this opportunity for this health summit. And I have a special emotional attachment because right from the year 2007, when eHealth was started, I am associated. Now, today's summit is really very important, and not only important, but from the national perspective, probably a very key and crucial issue as far as our country, India, is concerned. And this is that how the health financing at the bottom of the pyramid, we need to really prioritize. Now, dear friends, I am a public health specialist of the Central Health Service, and I have spent my career right from 1975 with the global smallpox eradication, and I have already eliminated leprosy with my research work and eradicated the guinea worm disease from the country. So while heading the major national health programs, probably I can share some of the crucial issues of your bottom of the pyramid, as you're calling, and this is the most important issue. Now, we know that our country is a very large country with more than 1 billion people. And these 1 billion people, we are staying in almost more than 6 lakhs of the villages. And if you take the 6 lakhs of the villages, our next administrative unit becomes a block. And there is a block development unit for every 80,000 or about 1 lakh people. So we have got more than 8,000 blocks. And then above the blocks, we move into talukas. And then finally, the governance unit is called the district. And we have now almost about 630 districts in our country spread over in 35 states and the union territories. And that shows that what large infrastructure we need for the health. Fortunately, unfortunately, when you talk of the health is a very crucial issue for any country. And country like India, especially more because of the large population. And we know that one of the biggest public health problem of our country is the population explosion. We are growing a very high growth rate of birth rate of more than 27,000 people. And fortunately, the death rate is really reducing. The life expectancy, when I passed out from my medical school in 1974, the life expectancy was hardly 40 at the time of birth. But today, the life expectancy is pretty good. It's crossed more than 60. And for the female, it is better than male. Now, which is a good indicator, in fact. And the primary health care of our country is one of the very sound and probably the best in the whole world, as a matter of fact. Because we are in a very organized system of healthcare delivery. And I can see some of the youngster colleagues here who may like to understand that our healthcare system is being implemented in the country. Now, we know that for every 5,000 population at the peripheral part, because we are living into the villages, we have got one sub-center. And this sub-center is looked after by 2 multipurpose health workers, male and female. And their job responsibilities are so well defined because maternal and child health is an issue on one side, and the other health and sanitation and environment factors are another side. So the female worker, whom we call as a ANM, auxiliary nurse midwife, she is in fact 18 months trained after her 10th standard pass. And we have got the schools at the district level, they're called district ANM training centers. Now, she looks after a very crucial part of maternal and child health. The male worker, her counterpart, He also is a trained person for almost 6 months to 1 year, and that gentleman we call multi-purpose health worker male. He looks after other health issues, the health education issues, and also helping in various family planning measures. And then for every 4 sub-center, we do have one supervisor. Female supervisor we call lady health visitor, and the male supervisor or the health inspector. And then we go up for every 25,000 population, we have got the primary health center. Now this is the point where the first contact with the doctor, because this primary health center is looked after by a doctor, a qualified medical doctor, and in our country we have by large number the allopathic or MBBS qualified doctor. And then this is the first point where there is a pharmacist, where there is a laboratory, and where there is the statistical compilation of the health at the ground level. Now this is a very key unit for primary health care. And then when we move up, for every about 1 lakh people or for one block, we do have established the community health center, which is 20 to 25 beds hospital. And this is the first point of the secondary care. And this was initiated, I remember when I was heading the maternal and child health division in 1996, we started reproductive and child health program, which was launched in 1997 in September by Honorable Prime Minister then. And the need was that there was emergency obstetric care was required for the women, because large number of women die for various pregnancy related issues. The large number of our newborns, they die for various preventable diseases. So it was felt that for this 1 lakh people, let there be a first referral point so that our mothers and children, they don't die. And that is why the 4 specialists were kept: gynecologist, the pediatrician, and anesthetist, a surgeon, so that they can take care of these people. Now that means, now if you try to understand, 6 lakh villages, then we have the sub-center. And today we have almost 1,46,000 sub-centers. Above that, we are going to the primary health center. We have almost 24,000 primary health centers. And then we go up is a community health center. We have almost 4,200 or 300 sub-centers, community health centers. They're short. They're not full. Because I told you that we have more than 8,000 blocks. So that means I expect that every block should have one community health center. So we are still short, but then government is taking time, because it's not that simple to establish a healthcare unit. Now when we move up, the reporting unit or the governance unit is the district. And the district chief medical and health officer, there we have the district hospital, which may be minimum of 300 beds and above, where you have another second care services and specialists are available. Now this becomes, again from the community health center, the patients can go to the district. And then you go up at the provincial level, at the national level, you have the tertiary or the specialty and super specialty. And wherein, again, a public-private partnership in our vast country is necessary. Now, why I'm trying to narrate you is this, because your topic today is the bottom of the pyramid. Now, I told you it's a pyramid, because the largest people, the healthcare is needed, and then as you are moving up, you are landing into the tertiary or super specialty. Now, have to be very clear in your mind that we don't want people to be sick. None of us want it. We want people to be healthy, our communities to be healthy, and then only our nation will be healthy. So obviously, we need to create more of the preventive and the promotive care at the ground level, so that we can prevent the occurrence of an illness. And if a person gets ill, then we must have the prompt attendance at the first healthcare delivery point. And then we should be able to handle it at that level. But if some kind of a complication is required, you need the specialist at the referral point. So that is how we grow like this. So very importantly, the primary and the preventive and the primary health care becomes very important. And in a country like India, if you can see, your pyramid is too big. The base of the pyramid is very, very big. And that is where we need to invest in the healthcare. And without health, we cannot progress. Enough has been realized that if people are not healthy, if people are not educated, you cannot grow into economy. You cannot develop. And I'm sure this concept was revised. Earlier country was working that we focus on industry, we focus on the economic, so country will grow. No. It was realized that if people are not healthy, even if you create industry, if they don't give your proper work output, so where can you grow into economy and development? So the whole issue globally, it was viewed, and the commissions, the global commissions were created for macroeconomics and the health. In that situation, it was realized that invest on the health and education, and then automatically the growth will come. So we do have the national commissions on the macroeconomics and the health, and the report for this was submitted way back in the year 2005. I don't know whether some of you would have definitely seen that report. Again, the emphasis is for development, invest in the health. Now, investing in the health, again, as I was trying to tell you, we must start from ground and up level. All these three tiers are necessary: primary, secondary, and tertiary. But then, in order to prevent the ill health, your primary or the base is very important. So if we look into that issue, I think we all realize that why the e-health has taken the subject of investing in that. I'm not going into the detail. I'm sure we are here, the colleagues, we have to work in the partnership, because the government alone cannot take this challenge. And why should the government alone do it? Because there have to be a partnership between the people themselves, between the government, and between all those players who are responsible for the development of the country. So that is why a partnership approach comes, and it should be the responsibility of everyone, every partner. So every partner has to appropriately define the role. And that is why many times in the e-health or wherever I get an opportunity to speak or chair, I always emphasize that this partnership has to be very, very strong. And people, those who are working at the tertiary level, they establish the tertiary level to begin with for the economic or for the output or for the benefit purpose. But in the health, we have to go more of the cost investment in the money form, but the effect, which is very difficult to convert into money. So it cannot be a business equation. In the health field, it's very difficult to make health benefit. In the health, you can only invest money. Input can be counted into the money, but the output is very difficult to convert. As I told you, today my maternal mortality ratio is almost 300 per lakh live births. And when I started my career, probably it was estimated to be more than 800 or even more. That means for every 1 lakh in 70s, more than almost 1 lakh, out of every 1 lakh, 800 to 900 or 1,000 mothers were dying for no fault of theirs. And even today, 300 mothers out of 1 lakh live births are dying. Now this we could reduce. Now if we could reduce, that time the life expectancy for a woman was hardly 35 years. But today the life expectancy for the woman is almost 62 years, and for the man it is 60 years. And why it was low? Because the mothers were dying because of the various maternal mortality related issues. So now, how can you convert them into money? You have reduced by investing money the maternal mortality ratio, which is still too high, very, very high. This is a dubious distinction. But what I'm trying to emphasize is from 800, if you can bring it down to 300 with proper investment at the down level by creating the essential obstetric care service, by investing for emergency obstetric care service through community health centers, or by investing at the secondary level, you can't convert it into money. It is a development. Mother is alive, mother is educated, producing less will further educate the children will be healthy, and the country will grow. So it will be an overall impact into the economy, overall impact, and that is why our country has already picked up, and women empowerment has really taken, which is a very, very powerful tool in the country. Empowering the women is really going to make a sea change in our country, which is making. So this is what I was trying to tell you, was that it is the investment, and we can't convert it into money. So why I usually say the corporate sector, which begins as a care as a service, but then they do have back of mind that what benefit I'm going to get. So I always tell my corporate colleagues, well, benefit has to come automatically, but also please discharge the responsibility of providing the health care in a true sense. So please link your tertiary care down to the most primary care, because the people who are coming to the tertiary care, they are coming from where? They're coming from the ground after they have failed into primary and secondary. That's why they have to reach the secondary. And none of us want that people should grow into this complicated case, that where tertiary care is needed. We need to prevent it. We need to minimize it as much as possible, because some of them are linked to our environmental factors, some of them are linked to our own self as a lifestyle problem. Like at those days, the trend was more of a communicable diseases, the mortality was high. But today, the heart attack is common at the age of even at 20s. And I never saw heart attack at that time less than 40, 50. But today we're doing it. Diabetes was not that high, but today the diabetes is there. Even the things are increasing, the strokes are increasing, the mental health problems are increasing. Now these are all related lifestyles. Now why should a person for hypertension should run to a tertiary level? Why should a person with a mental health problem which can be taken at the ground level, why should we make this person to traverse right up to the high level? People are living in the village. Even going to the district level and going up is not that a simple task. So idea is to take the healthcare services at the doorstep of the people. That means reach or increase your outreach, go as near as people, where people are living. You can again prevent the expenditure of the people going to that place, and you can relieve them because of their tensions, you can relieve them because of their various other issues. Now this is also kind of an investment, as a matter of fact. So that's why I always tell these tertiary level institutions that please link to the primary or ground level. After all, people are coming from there only. Analyze that epidemiologically, that who are the people they are coming to your tertiary center, what kind of socioeconomic background they have, and why they got this illness which forced them to come to their tertiary level. If they analyze these factors, I'm sure they will assist the secondary and primary level in mobilizing the better services, healthcare delivery. And it can't be done alone by the government. People have to be involved. Now, these are some of the very crucial challenges. Health information is the crux of the whole thing. Information is the power. And without information, nothing can be done. No planning can be done. No policy can be decided. No strategy can be really monitored and evaluated. And no corrective measures in the time can be taken. Now, this information, again, has to come from where? It has to come at the national level from the most peripheral and ground level. Now, this is, again, a part of the healthcare. Because if you don't have the information flow, no level we can plan. Now that is why IT or ICT has become a very crucial component, because this is a mechanism by which information can flow very quick and fast up. And this is a big challenge at the most peripheral level, let me tell you. I am handling the entire intelligence. Still the reports from the sub-center to the PSC has to be delivered by hand or by post, and it takes a lot of time. And even from primary health center to the district, the monthly reports have to go by and large by post. It takes a lot of time. There's a lot of time gap. Now why can't we why can't IT, why can't the corporate sector come and devise that we have the handheld computing devices at the most peripheral level so that the data goes? So is it not reducing the cost? Is it not increasing the efficiency? And once the efficiency increased, is it not saving the money? So actually this right investment also saves a lot of money wastage. Now this is a big challenge in the health. If we don't do it, it will be difficult. I'm sure the IT expert did come, and every time when I address them, this becomes an important issue. And I know that IT alone cannot do anything, because IT is a system, is a mechanism. They have to sit with the professional. They have to decide what kind of programs, what kind of software need to be developed, what kind of hardware need to be made cost effective, cost operationally economic. So again, this is a challenge for investing at the bottom, and we need to invest at the bottom. Government of India, through the 5 years plans, through the annual budgets, is definitely increasing. You know that we used to be spending 3% of the total government funding on the health. But today, it has almost gone to more than 6% of the entire government plan every year, every 5 years, we have gone to that. Even of the GDP, we were very little, less than 1% of the entire thing was done, which is now present government is committed to take it to 2% or 3%. It makes a lot of difference. And you know it, that ICT government has taken with our Honorable Prime Minister Rajiv Gandhi, who brought his friend Mr. Sam Pitroda. That was a revolution to bring ICT in our country. And today the Ministry of Information and Communication has been established, and 3% of the budget for every ministry, every department, every organization is a compulsory to be investing on ICT, so that they can be appropriately increase our efficiency. Now, this is again why I'm telling that all these issues are investment issues, and not only for the purpose of earning the benefits. Benefits are going to come after time. In the health, you can't expect the benefits or effects quickly. Slowly, slowly, once they built up, they are going to be sustained. So our funding, finances need to be gradually up and sustained. So that's how the health will improve. National Rural Health Mission, you all know, it was launched with this idea only. In 2005, April, again our Honorable Prime Minister launched this National Rural Health Mission. Objective was very clear, that we do have primary health centers, we do have primary healthcare system, but still there was a problem because of the outreach. Our services were still not reaching to the people, or because of the inefficiency of the system. Every system doesn't work efficiently, whether government or private. They are relative term. We need to improve the efficiency in all the sectors wherever we are. And attitudinal problems, managerial problems, logistic problems, the various problems relating to the operation are always inbuilt. So we need to handle those problems also. So we need to invest in the management issues. And this is also investing for the healthcare. If we can improve the management, like drug delivery, the logistic supply, replenishing it, all these things, they need attract and investment in a proper manner. I think this is again ICT and various other management issues are becoming. Now we have amply realized that it is not just alone the doctors, it is not just along the paramedics, but probably the IT experts, the management experts are also needed at the district and sub-district level, so that a holistic approach and functioning can be taken. I'm sorry I'm taking a longer time, but I thought to begin with this, in order to clear the meaning of the subject, what Dipanchan and Ravi Gupta have kept, we must all understand it in its true sense. And thank you very much. All learned panels are here. They're all representing the private sector. They're all representing a partnership in our country and for our country for going together. Thank you, please. I think the system is now probably each of our panelists have to be giving their view. I'm sorry I've taken a little more time, and maybe by the time our colleague from WHO advisor may also join. Are we going any sequence for inviting, or we just start from you and then we'll move like this, please? Thank you.
Thank you, Dr. Ashok Kumar. I'm Sundararajan from Siemens. It's good to know the big steps that the government is taking for bottom of pyramid rural healthcare. Somehow, in the past few months, past few years, bottom of pyramid has become analogous that no one can make a business out of it. First of all, let me start by saying, it is it's grossly incorrect. If you see the telecom revolution in the country, out of 1 billion population, 550 million have mobile, and they have been connected to some service agency for the mobile network. So it is not that the bottom of pyramid will not pay, or the rural masses who are even below poverty line will not pay. It is just that probably awareness and accessibility today is not there about healthcare. That is number one. Number two is that I don't think disease pattern differentiates between the bottom of pyramid, rural masses and the urban masses. It is polarized, it is uniform across the country. Since awareness and accessibility is not there, people don't go. Who are not sick, they don't go and get themselves scanned or get themselves screened. So, some kind of a solution where I totally agree with Dr. Ashok Kumar that it is not entirely the government's responsibility. The private players, including the healthcare corporates, have a major role to play. But unless we can put in a mechanism by means of which we can combine rural screening at early health stage when the disease has not occurred, plus insurance, and then feeding into tertiary as a PPP model, I think the situation, will continue to remain the way it is. So that is a major point which I would like to make. Dr. Offer.
Good afternoon. My name is Dr. Itamar Ofer. I'm from Elbit India Healthcare, and we are into the hospital business. I can humbly say that I am not a consultant to how to treat 800 million people. Coming from a small country like Israel with 7 million people, the whole country, I cannot give advice on how to do it right here. But I would like to share with you some experience that we have since due to the fact that in Israel we have a national health insurance law, and due to the fact that every citizen of Israel is covered almost fully, actually fully, but the unique new technologies. The community-based healthcare is very, very much developed. And I think that I would like to give only one example that can be, I think, implemented or start being implemented, maybe now because of a specific event that is happening, which is measuring. Dr. Ashok Kumar have mentioned the time for the reports to come from one center to the other, to the district and to here. And you didn't mention anything about the quality, but one thing is sure, those reports were made by people that may have some interests in the way they look. Not only in India, everywhere in the world. The moment a person is making a report, someone may have an interest in the way the report looks like. What we implement in Israel is health quality measures that we implemented in the systems. Now, the unique opportunity that is happening today in India is I don't remember the name of the project, but the Unique ID project. Mr. Nilekani, what's the name of the? Yeah. I believe this is a major event from the healthcare point of view in the life of healthcare in India. Because the moment you have a unique ID, you can start measure seriously. Now you can start measure with very, very simple things like laboratory results. All machines today are providing digital information. The output is digital, no? You just have to recruit this digital information to connect it to the unique ID and start measure. And I'll give you an example what happens when you start measuring. We did not measure until 10 years ago or 8 years ago. And we started measuring, let's take diabetes. We have diabetes in Israel too. And we started measuring first whether the people are doing their annual checkup. Okay? Even when it's free, by the way, people are not coming to do it. It's not only because of money. Even in Israel, when you are totally covered, people are not coming to do it because of different reasons. The idea of measurement is that we provided information to the care providers about the percentage of people who are doing their annual checkup. If it's eye checkup, urine checkup, blood checkup, whatever. That was the first layer. The second layer was, of course, the results. So whenever we could follow up on a regular basis on hemoglobin A1C, and to see what happens with the person. And we could provide information to the care providers, to the doctors, of their own patients, how many of them are controlled, in how many cases the diabetes is controlled. So that's a higher level. And the result of just providing the information was, of course, improvement because they started calling the patients that are not controlled, checking with them what happens with the drugs, what happens with the diet, etc., and change the whole picture. And we reached a phase where 60% of the diabetes patients were with the hemoglobin A1C below 7, which is controlled. This is a very, very high number. What I'm trying to convey is that continue to walk in the same path will not work. And nobody can provide a medical health record to every person in India today. We have to start from very, very simple but contributing things. Now, why is it paying back? It is paying back because those diabetic patients are going to lose their kidneys, to lose their legs, to lose their eyesight, and to be a burden on society. They're not dying. They're not dying in one day, and that's, cynically saying, easy, because they don't cost anymore. They continue to live in the society and to be a huge burden on society in terms of employment, in terms of another a person to feed, etc. But if you postpone the complications, of course, the value to the society is huge. And by the way, with the right people, I'm sure in your team you have them, you can calculate the exact rupee cost of those initiatives. So again, humbly saying that you cannot copy-paste things from one country to the other, especially not from a tiny country to this country, but think very, very simple, and trying to use this event of the UID, I think it's as a unique opportunity. Thanks.
Thank you. This is Dr. This is Dr. Naveen Jain. I'm the medical director of Pushpanjali Crossley Hospital in Ghaziabad. I feel whatever Dr. Ashok Kumar has said, there's a huge requirement of entry of the private healthcare players in the rural sector. The first and the foremost thing is because all private healthcare providers need a sustainable model. They have to profit from any work they do in rural areas, and I strongly feel that all these models have to work on a profit. Naturally, they have to earn profits, and they have to some sort of incentivizing from the government so that the private players can enter the rural market. Hospital chains like Apollo and Fortis and Vocart, or you name it, everybody, in fact, many of the chains have started, the Columbia have started building up secondary care models. Corporate chains are ready to go into the rural areas, provided some sort of incentive or a subsidy comes from the government side. And naturally, the other things like the doctors have to be very comfortable working in rural setups. So a lot of things have to happen sideways.
Hello everybody, I'm Rajiv Gulati. I'm working with the Haryana State Electronics Development Corporation, is better known as HARTRON. And that's an implementing agency for different projects under e-governance. And fortunately, e-health or healthcare and the industry comes under me as for a couple of things in Haryana. Now, as per my history, I can say since 1984, I am among the, my core thing is from the technology side. In 1984, I was among the team member who first created the India's first brain scanner. Okay, so what I am going to share with you is small experiences which I have got through this all 25 years, even working with government up to the PhD and CSC level, where I was also doing EMMC project. It was from Ministry of IIT previously it was called Department of Electronics, where we used to go for maintenance of the equipment up to that level. And how important is it to provide the health to at the bottom of the pyramid. Now, I will take one or two examples. Like when we say we are talking about when the revolution of IT began, it was used to call as information technology only. And somebody in India also from ministry said what the technology is going to do if there is no communication between it. So they put in a word between that, the CT. So it was information, then the communication, then comes the technology. Now, whatever we are thinking of providing the best health, as Dr. Ashok Kumar also said, to the maximum people who are lying at the bottom of the pyramid, all these things like information, like communication, and like the technology become equally important for that. Whatever the policies and all those come, I mean, those are just in the path on which we can travel all these things. But unless until we have got the information which can transfer from the bottom line at the fastest mode to the doctor or to the health provider, and the communication modes of that, and the technology which can transfer this information at the fastest route, nothing is going to happen. I mean, that's my very personal view, because I'm taking one or two examples. Like, if somebody met with unfortunate accident in the village, what he has to do? The very first thing he has to go for is simple X-ray. Small, for finding out whether there's a fracture or not, he has to go for X-ray. Maybe slightly costly, but can't it be provided up to the PSC level or CSC level, where that digital thing can be transmitted to the doctor, and he can immediately tell to the person what to do, and what the first aid he can provide, and there's nothing to bring that for a small thing, the patient to that particular place on a motorbike or a trolley. Okay. Now those technologies are available. Now people started talking about the DRs and all those things. I mean, those costly, but there are alternative solutions which can scan those things and can send the image to, and there are now the channels available also where we can transmit the data also. So that's a very small example. I mean, I was attending one seminar where Dr. Matthews, Laser Matthews was there. He was talking about, it was way back in 2000 when video conferencing was a big deal in India. So he took an example of a Kumbh Mela. So they have got a limited doctors which were sent to that Kumbh Mela, and whatever the things are, they had to transmit it and taken help of the AIIMS, just putting them the things on the video conferencing. Now, very interesting incident was there. They were trained on what to do when dog bite is there and all those things are there. But that policeman, he got there's a man biting another man. I mean, what to do? And then they put on the conference, and then they said, okay, you give this treatment and go ahead. So I'm talking like there are methods which can provide these facilitate these things at the bottom level, and there are projects which these young entrepreneurs or these can take up over there. Take another example. In 2003 or 4, this is an example of Safdarjung Hospital. Records of X-rays. A huge room which are full of X-ray, which they have to keep the slides with them for a couple of years. And I was talking, I mean, why can't you digitize this? And then assessing that record, I mean, it took long time. I mean, I think in the morning session somebody was talking, I mean, if the records are all accessible, 15% of the deaths can be saved. So similarly, the bottom of the pyramid is becoming so important for providing them the technology. I know, I mean, everybody now has an access for BSNL or whatever there's communication where the data can be transmitted from them very easily. There was a big question at that time that how we should transfer this heavy data from that place to this thing. Now only we have to provide the technology, provide them the access. The doctors have to be taken into confidence, which can be trained on this technology, 24/7 can be made. And the technicians who are not aware, they are still scared of how to use the computers. They have to be trained on that. So ultimately, we have to train the people over there, induct the technology which can transmit the data from that place at the earliest possible, and utilize our doctors into 24/7, and we can cater to that bottom at the earliest possible stage. Thanks a lot.
Well, you know, it was quite interesting from our colleagues on the panel, like Dr. Sundarajan, Dr. Naveen Jain, and Dr. Gulati. I think everybody feels the need, and there is a commitment for doing that. And some of the components have been added. Like Dr. Etamol gave his Israel experience, and he could really emphasize that yes, they have used the technology, and now at the end of 10 years, they're really rearing the fruits, and probably that is making the cost effectiveness into the program. And he was very clear about the issues like insurance, because in country, healthcare we have to really, it's a purchasable commodity obviously, because we need to. So for that, insurance coverage. And let me share the information that Government of India made the insurance for the people below the poverty line, wherein almost 60% the government will contribute, and about 40%, very nominal amount, the people will contribute, and then we take care of their healthcare expenditure. But still, that kind of an amount, when we think of the modern medical care, probably we still need to go for a larger funds to be raising. And then those who can afford, the various companies are there, and we do have IRDA, the Insurance Regulatory Development Authority, which is really going, moving into this direction, that we can emphasize on the insurance issues. And he demonstrated the importance of information flow from down and how it was used, and he demonstrated that how, taking the example of diabetes, the impact. Now, unique ID, yes, now the country is really taking it, and I remember once I was giving a comment that how it can be applied into the health, and as you rightly said, once we have that unique ID, we can link it, and the health records can be created right from a very young age till probably whatever old age, and it is going to economize and suffering from them. Now, Dr. Naveen, you have also raised a very important issue, that in the partnership, some kind of incentive from the government to the private people. Now, issue is we have to still be very clear that what are these incentives. Because in a partner, we all move together. Both of us have to put these steps together. Now, this incentive issue, if it is a money incentive, which is always not a very good answer as an incentive. The incentive can be on various other issues. And many times the government feels, as I was telling you, in the partnership, let everybody contribute it. So, when we say that the private sector or private group also need to invest for the development of the country, and they probably need. Now, here I can give partnership also makes, like many times we face, we have the data or information only from the government sector, and we don't have any information from the private sector, though almost 70 to 75% of our people are resorting to the private sector. The information, the entire national database, which we through the Central Bureau of Health Intelligence for the whole country are handling, I can never say that it's a complete data. I can never say that you can do absolute correct planning out of it. I can never say that I can take proper corrective measure, because these are only indicative, because we are missing a large data. We are having by and large the data of only, for example, inpatients. The outpatient data, 90% of people, those who are taking outpatient, we don't have the data. Now, these are some of the issues we need to really address. And then when Dr. Gulati was very convincingly telling the impact that how the IT can economize our services. But maybe only initially we need to invest, but then the dividends we are getting is so great that we can reinvest those dividends and multiply our outcomes. I think this was the little. I think you wanted Dr. Jain to say something.
No, I think it's already been answered.
Yeah. So you know, this is the issue. I think now we can keep the panel open for the House, please. Anybody would like to raise certain kind of even comments, please? It may not be question, but it can be a comment or, not. You see, I always felt, even if you make an effort, please. If not, okay, then we still have a time, and I think I take the pleasure of welcoming Dr. Arna Surzadi, who is the regional advisor on the gender, women, and the health from our World Health Organization Southeast Asia region, and she's here with us, and maybe she will be making a presentation. So, Dr. Surzadi, you coming here? Okay. Yeah, please.